Thank you for coming. Folks, this is Dr. Jonathon Tomlinson, who's a GP, a medical teacher, medical educator, a man with an interest in health policy and particularly about deprivation. And we're going to talk about shame, particularly as applied to medicine. Jonathon, thanks for joining us. How did you get into the idea of shame in medicine to start with?
So like a lot of things I got into, it started with being stuck with patients. And I remember it quite clearly. He's still a patient of mine a good 10 years after this moment. But he was a guy with multiple multi-morbidities, but unusually for where we lived, he was fairly sort of well-educated, reasonably middle class. And we had a good relationship. And I saw him in the waiting room one day when he didn't have an appointment. And I just came up beside him and put my hand on his shoulder and said, "Oh, hi, how are you doing?" And he, instead of looking at me, he turned away and tried to kind of escape. And I could smell that he'd been drinking. And it was clear that he was, he said, I can't, I'm just so ashamed. And just walked out of the surgery without waiting for his prescription and looked very embarrassed. And I was quite upset. I thought we had a relationship where he could say, "Oh God, I'm embarrassed, but I'm so glad you're here, and we need to kind of talk about this." But he wasn't. He just left the surgery. Didn't pick up his prescription. I didn't see him again for about a month, and he was quite unwell when I saw him. And I thought, what could be so bad that somebody with whom I thought I had a good therapeutic relationship could be so ashamed as to, leave the surgery and jeopardize his own health. And the word shame and ashamed kind of struck me, and I thought, well, actually, maybe I should think about this a bit more. And it was about the same time that Brené Brown, this American social work professor, now it's almost celebrity status, she'd just done her TED talk on shame, which had about 1.5 million views. And I think I'm right in saying it was the first TED talk to get over 1 million views. And it was a tremendous sort of 19 minutes just articulating exactly what shame was and why it was different from guilt and why it was so incredibly harmful, and how we, more importantly, as somebody in the business of caring, what you should do in the presence of shame. And it was immediately relevant to me because she explained why people who experience shame, in particular what we might call toxic or chronic shame, don't engage with healthcare. These are the patients who don't turn up to your appointments. These are the patients who don't take their medication. These are the patients who end up with problems of addiction and self-harm. These are the patients who, in inverted commas, don't take responsibility for their health. These are the patients with whom you really kind of struggle. And it was suddenly shining, as a GP who'd been working sort of flat out for 10, 15 years in a deprived area, becoming an expert in my own field, suddenly shone a light on an area that I'd been totally bewildered by for years. And it was incredibly helpful. So that made me get on a journey of trying to make sense of it and to try and help myself and my colleagues to deal with patients who we were, all stuck with. So that was the beginning.
Thanks. And did that help for yourself, as it were, start with just the concept of that person has shame about their situation? Is that what?
So it's massively helpful for me. So, or in general practice, especially where I work, we have continuity of care, which means you have your own patient caseload. So you have people who you can't discharge when you're stuck. Yeah. So if you're in another specialty and you're stuck with someone, you can say, well, I've done my bit, their inflammatory markers are normal, back to the GP. Yeah. Or, the heart's okay, back to the GP. We've done our pain thing, they're still in pain, but we've got nothing else to offer back. So we're stuck with these people forever. And you can be driven to the point of burnout as a GP if you're stuck with loads of people for whom you feel you can do nothing, because your self-worth as a doctor is tied up with being able to do something. And if you can't do something and you can't discharge your patients, after a while in general practice, you collect more and more and more patients who you're kind of stuck with. And so for my own resilience and satisfaction and not going completely mad or giving up or being burned out, I had to find ways of coping with people who I was otherwise stuck with. And dealing with shame was an incredibly useful way of helping with that.
And is that partly acknowledging that they have shame about their condition, or do you have any shame about not being able to I'm putting this in inverted commas, not being able to do something for them?
Yeah, so I think your professional identity becomes enmeshed with your other identities. You're a whatever. I'm a dad, husband, son, a bunch of other things beside being a GP. But after a while, one bleeds into another, and your sense of yourself as a good person, morally good, becomes also muddled up with your sense of being technically good, having good levels of knowledge, being a good teacher, and all that. And so these things all become mixed together. And so if you find that you're kind of failing to help people, then it doesn't, you don't say, well, that's fine, because, in every other way, I'm pretty awesome. You begin to think you've kind of failed as a human being and not just as a kind of doctor that fixes people. It's not just the medicine that's broken, it's kind of you. Or it's not just the pills that aren't good enough, it's kind of you're not good enough either. So being able to deal with that gives you day-to-day, moment-to-moment satisfaction, which is, helps you to kind of move beyond getting through the day and think I can actually quite enjoy this. Lots of my colleagues are thinking, I'm dead on my feet and I can't wait to retire. But you're thinking, no, I'm still really digging this, and that's really good.
I mean, sounds like this is not about me, this is about shame, but that there's also some parallels with working in a hospital, of course, where we don't always cure people. In fact, it's not that common we cure people. In fact, as an anaesthetist and surgeons, we temporarily harm them and maybe permanently harm them. That's not for now. But so I think you're speaking about something that's relevant to general practice, but also to the wider medical community, including doctors in hospitals.
Yeah, well, I hope so. I mean, I don't doubt it, and especially under present circumstances where an awful lot of people, of course, aren't surviving. And then this probably helps at this point to define what shame is and why it's kind of critical. So if you imagine, people talk about guilt and shame almost as if they're the same thing. And guilt separates the deed from the person. Okay. So if, for example, I didn't send my mum a card on her birthday, like it might have been a bad thing to do, but it doesn't necessarily mean I'm a bad person. So, or if you get you don't act on a blood result in a timely manner and the patient is harmed, there's some harm there. It was a bad thing to do. It was it could be considered neglect, but it doesn't necessarily mean that you're a bad doctor. You could have just had a whole load of other pressing concerns on that day. You could be absolutely shattered and it just slipped your mind because you were too busy trying to do a whole load of other really important things. So separating, guilt is when you think I did a wrong thing, but there's something I might be able to do to make it better. Or I'm going to apologize for this and I'm going to try and fix it and I'm going to do a critical incident or whatever. But it's the deed rather than you as your kind of identity as a kind of flawed person. Shame is where you believe that kind of doing bad things is kind of inevitable because you're the kind of person who screws up all the time. You're the kind of person who's fundamentally flawed, and so things that go wrong are bound to go wrong because that's just the kind of person you are. There's something fundamentally about your being. And that goes back, in the case of toxic shame, as far as you can imagine. So you look back at your life and you think, basically, I was kind of a mistake. Guilt is, I made a mistake. Shame is, I am a mistake.
Mm.
And I look after someone who had a series of, a couple of siblings died in early childhood, and he survived, but always was left or given to feel by his parents that he shouldn't have survived. He should have been the one that died and not them. He was, they were the favoured children. He was the mistake. And he was, he basically wasn't supposed to be here. And he's internalized that because it was part of his very earliest development, and has spent his whole life feeling suicidal and acting on those suicidal thoughts because he can't understand why he's still here. He's the same age as us, in his 50s, and still carries this intense sense of shame that he's it's because of him that his siblings died, it's because of him that his parents suffered. And even though somebody put those thoughts into his head during childhood, it's never left him, even in his 50s.
So you mentioned toxic shame. You mentioned shame, guilt, shame, and toxic shame. And how is toxic shame different from shame, which seems quite all pervasive in itself to me?
Yeah, so shame has kind of cultural dimensions, and there are some sort of cultures in which shame is perceived differently. So that's probably one thing to think about. But specifically around toxic shame, it's that shame that begins in early childhood experiences, which is why shame and adverse childhood experiences or developmental trauma are so closely associated. In fact, there's a useful definition of toxic stress or childhood trauma, which says that it's a constellation of shame plus dissociative symptoms plus fearfulness. So you're presented with a patient who's extremely anxious, who has a very low opinion of themselves, who's probably self-harming, who's probably tried to kill themselves, who doesn't engage with care, and has maybe functional neurological symptoms. So the kind of people you see in A&E a lot at night, often young women who are more likely to experience sort of trauma or abuse when they're growing up. And so then you sort of see shame manifest in these ways. So it goes with anxiety, it goes with self-harm, it goes with addiction, it goes with functional or medically unexplained symptoms, it goes with so-called personality disorders. So this would be toxic shame. So it's instilled in you by what happened when you were young. And the reason it happens then is because a young child is by the way their brain works, they're naturally a narcissist. So if something happens, their parents argue, they fight, one of them leaves home or one of them dies, a young child will think, what on earth did I do to make that happen? So they will look for how was I the agent of this terrible thing that happened? And they probably won't tell anyone about it, or it will become an issue of shame if they can't tell anyone about it. And so that's what I would call toxic shame.
Okay.
Acute shame, or kind of normal shame that people have, is an acute sense of, oh my God, I forgot my mum's birthday. That's like the second year in a row, and last year I felt really guilty. There must be shit. I'm so bad. That's like acute shame. Like I really have screwed up this time. It wasn't just a bad thing.
Not necessarily associated with a long-term shame. It sounds like
no, it's not. It's not fed by what happened when you were growing up. So toxic shame is kind of goes back. It's a deep-seated thing that goes back to childhood, I would say, and very, incredibly sort of harmful because it's associated with these ideas of I'm just not worth it, and I just shouldn't be here, kind of thing. And one way you might get into it is speaking to somebody about their childhood when they had feelings of intense shame, but they just couldn't tell anyone about it. So it isn't inevitable, but if there's nobody there with whom you can share it, who can say to you, you know what, this isn't your fault. So kids who are abused, for example, especially by a parent, you know, who couldn't tell anyone about it. So they just had this to deal with in their own head when they were growing up. It becomes rationalized, well, maybe there was something about me that meant that it was somehow my fault. Because there was nobody else there. There wasn't another adult in their life who could say, you know what, this is wrong and this is not your fault. This shouldn't be happening.
And especially with parents, of course, our parents are our gods, right, to start with. And so if they're doing something wrong, then that must be right to the child.
It can't be their fault. That's absolutely true. And I've done a lot of work on shame and trauma with a couple of women. Actually, I spoke to them today, and they say exactly the same thing. You know, as a child, your parents are gods, and if your dad's doing something which you think is wrong and that hurts, but it's your dad, you don't, you know, you have to kind of think, well, maybe that's just supposed to happen. So it's very, very confusing for a child. I should also say at this point, these the people I mentioned are doing incredibly well. Like we joked, one thing I'd like to say, people often think, oh, these patients, there's so much trouble, they never get better, you know, they've got personality disorders, forever. They're doing so incredibly well. We joked today that we might not be able to do the trauma, shame teaching anymore because there will be the people who used to have trauma and shame but don't anymore.
Yeah, wow, that would be, that's right, that would be a good thing.
Which is really nice.
Yeah. John, I don't want to sort of move straight on to the solution. Now, of course, there's not one solution, but solutions or options. But do you want to talk about any other patients that you have seen, or would that be useful?
I could do. I was going to mention the example of the anaesthetist, not because you're an anaesthetist, or because it's an interesting story that had a big response. So the example was of an anaesthetist called Joe, who had a panic attack during an operation and couldn't carry on, and you know, who was sort of sweating, shaking, couldn't make a decision, and they had to call in another consultant to take over. And he was in a terrible state, and in the end had to be sent home. And he couldn't return to work for some time because he was so incredibly sort of anxious and not sleeping. He was really sort of mentally unwell, and he saw a psychiatrist and was prescribed medications, but after a few months was still unable to return to work. And it eventually transpired that the panic attack was triggered by opiate withdrawal, because he'd been using fentanyl, which he'd been stealing from work. He'd also been drinking quite heavily, but had managed to keep it secret from work and colleagues for a long time. And his background was that he was born in Sheffield. He was a single mum. His dad was an alcoholic who was really violent at home, and he was and left when he was quite young. But his mum was, you know, very sort of anxious and wasn't well herself. And to sort of escape the home environment, he would spend most of his time in the library, which is how he did well enough to get into medical school. So he always felt out of place. He kind of felt like he had sort of imposter syndrome, where you think, I'm really not supposed to be here, and how the hell did I end up at medical school? You know, working class kid from Sheffield, but did well. Wasn't crazy about patients, which may or may not be why he ended up as an anaesthetist, but he was clearly pretty bright. And the kind of the drug use and the alcohol kind of escalated in middle age as some of his sort of childhood shame and other feelings started to come back. So one of the things with shame is that you often go through not such a bad phase, late teens, early 30s, 40s, when you're very healthy, you're resilient, you're physiologically, physically strong, you're progressing in your career, you've got lots of stuff to distract you from whatever your demons are. And then, especially becoming a father or a parent, you're confronted by somebody who looks like is a bit like a mini version of you, and then you start to think about your own childhood, and then it starts to come back, and then you start to self-medicate. Anyway, so he ended up having a lot of sort of therapy and care before he was able to return to work again, like a couple of years later. So anyway, I wrote about this story and published it as a blog, and had dozens of people write to me and complain about breach of confidentiality because they knew this guy, but it was entirely invented. And I tell the story to say that, like, I don't believe that. I'm sure these people did know this guy, or somebody who fitted that description almost perfectly. But I've never had so many complaints about anything I'd ever written as I did about this. And the complaints were from all over the country. So they weren't all, like, it wasn't there was this one guy, Joe, in one particular hospital where everybody knew he was. There were lots of people from lots of different places who knew somebody who fit, whom that description was close enough to ring true. Which is to suggest that issues of sort of shame and self-medication and trying to cope with it and in the medical profession are prevalent.
Pervasive.
It's not to say that there are loads of bad, dodgy doctors out there. There are just lots of people who might have come into medicine because of what happened to them when they were growing up. And perfectionism and hard work are often ways to repair feelings of shame and not being good enough. So throwing yourself into your work, trying to be the very best, trying to satisfy other people by being brilliant, sometimes trying to deal with those shameful feelings.
Well, that's really interesting that it's so pervasive that multiple groups of people felt or recognized that person amongst them or their colleagues.
Yeah.
So how would you, let's slightly move on possibly to a sort of different angle. So you see a patient, perhaps I see a patient even, and I would think, they maybe are exhibiting some signs of experiencing shame, or not experiencing shame, but behaving in a way that suggests that they have shame. How can we use that therapeutically, or how can we help them through that?
Okay, so I suppose first of all, sort of signs and symptoms that you should think of that might make you think, okay, maybe shame is an issue here. So certain problems that people present with, so problems of addiction, almost 100% of the time will be related to shame. Anybody who's got a label of a personality disorder, you should be thinking of shame. People with chronic pain very often, people who frequently don't turn up to appointments, think about it, people who don't take their medication, even when they, like important medication, so people who are not taking their insulin or their antiretrovirals, or people who seem to sabotage their care. So these are the kind of presenting signs and symptoms in terms of behavior. People who are sort of angry and argumentative, those troublemakers, as it were, you could be thinking of shame. So these are the things you might think about. As an anaesthetist, you might be seeing people who repeatedly present with acute abdomens for whom you can never find anything wrong. And you're thinking, hang on, there's something going on here, and part of that will be shame. So ways to respond. I think that there are four sort of cardinal things that I would say that help. One would be validation. So validation is establishing trust with the patient, making them feel safe, and letting them know that you believe them. So validation is something you experience as a patient. You don't validate someone. Someone experiences, okay, this doctor believes me. So it's up to the patient to make the judgment about whether validation has occurred. So belief would be number one. Number two would be vindication. So vindication is where you say, you know what, this is not your fault. So there's a guy called Johnny Benjamin who is a mental health campaigner. There was a documentary about him called Stranger on the Bridge. He was on Waterloo Bridge and he was about to jump off to kill himself. And a guy was running past who was a personal trainer, and he saw Johnny stood on the bridge about to jump, and he stopped. And Johnny Benjamin, when he tells the story, he says this guy said some things to him that he'd never heard anyone say before, despite his years of mental health treatment. And this guy said to him two things in particular. He said, mate, it's not always going to be like this, you know. And all he'd heard before or remembered hearing was like, if you've got schizophrenia, you've just got to learn to live with this. You know, this is it for you for the rest of your life. And this guy, for the first time, said, mate, this isn't how it's going to be. Or, you know, things aren't going to be like this all the time. So things are going to get better. But the other thing that spoke to Shane was, mate, there's nothing you could have done that means you deserve to die like this. Like, whatever you think you've done, whatever you think about yourself, nobody's that bad that they deserve to die. So he spoke to that sense of shame that he knew was there. People might say, well, I've got nothing to be ashamed about because, you know, whatever. But I still want to die. Like, whatever happened, it can't be, you know, like, I don't know what it was. And people do, and terrible things happen to people. But if you're feeling that your life is just not worth living, then just consider for a moment that feeling was put into your head by somebody else, or is there because of what happened to you, not because of what you are or who you are. And the only way to find the right words is to practice with patients and to listen to them and to look at them and to pick up on cues, and it'll be slightly different for everybody. But once you've done it a few times, it's the most incredible, therapeutic, life-changing, literally life-saving, suicide-preventing thing you can possibly do. And one of the beautiful things I've had here is I've had final year medical students come in and see somebody and then respond like that, see somebody who's suicidal. Like, I don't deliberately put them in that situation, but sometimes it happens just because of where we work. And then they come out and say, oh God, you know, I did that thing, and the patient just completely changes that whole demeanor and manner and everything. And you just think that's, you know, that's advanced life support in primary care.
Hey, you said there are 4 things.
Oh yeah. So belief or validation.
Yes.
Vindication. Yes. Commitment.
Okay.
So you have to, the natural response to somebody who's feeling shame is to try and get them out of the room or get away from them, because it makes you feel uncomfortable. So that's the other clue you might get to a patient who's feeling shame, apart from all the behavioural stuff. But if you feel, I can't wait to get out of this room because I feel really uncomfortable, then probably the patient with you is feeling that about themselves. They're very uncomfortable in their own skin. So if you're thinking, I need to get out of here, then you're probably dealing with somebody who's got a lot of shame. So to recognise that and do the opposite of what they expect, because they expect doctors to treat them badly and tell them to get out of my A&E department, get out of my GP surgery, get out of my face, just take these pills, please don't come back. If that's their experience of healthcare, and it usually is, and you do the opposite of what they're expecting and say, you know what, I'm going to stick with you, and I'm going to be your doctor, and I'm going to try and help you because I believe you, and I know that the way you are is not because of who you are, but because of what's happened to you. And you make that commitment, it's incredibly powerful, and it's not what they're expecting. So commitment would be 3. And the 4th one is easy to say, but in practice harder to do, is just be kind. So,
I was literally thinking of the words, show them love. That's how I think about it in hospital medicine, but being kind, it's the same thing. It's just the same thing, isn't it?
It's incredibly hard to do when you're feeling exhausted, your emotional reserves are sort of sucked dry, you're not getting any love yourself. What you really want to do is go home and burst into tears, and then somebody's telling you to show the patient love, and you think, I haven't even got enough for my wife and kids when I go home. Like, how am I going to, so it's easy to say, and it sounds almost kind of flippant, but we should kind of recognise that it isn't easy to do. But like most things in life, the more you practice, the easier it gets. In fact, I have a big poster on my wall. I have 3 posters on my wall. One says remain kind. The other one says, I'm pointing at them because they're right in front of me where I consult. The other one says stay present.
Oh, okay. Yeah.
When you're feeling really stressed, don't sort of dissociate and start thinking about
wander away.
Yeah, stay present. And the other one says demand evidence and think critically.
Okay, they're not all mutually exclusive. Well, they're not at all mutually exclusive.
No, but they're right in front of me. So if I forget or I
Yeah.
get into a blank spot, be kind, stay present, think critically,
Demand evidence.
think of the evidence.
That's great, John.
So 4 things: validation, vindication, kindness, commitment. And easy to say, get better, like everything in medicine, get better with practice. And I kind of think, maybe for you as an anaesthetist, your kind of skills are kind of highly technical. Ours are kind of more relational. I mean, yours. I'm caricaturing here.
I personally would say that all I do now is communication. Really.
Okay.
It's all about the comms. It's all about the love before and after, and making sure, because all we do, this is not about anesthesia. This is for all the medical students doing. They're going to be going global health. They're going to be doing pediatrics, psychiatry, general practice, general medicine. But as an anaesthetist, all we try and do is make probably the worst day of someone's life up to that point okay. That's my thinking of it, basically. So I weirdly think I'm a generalist. In fact, I speak sometime to professor of general practice about being a generalist. So
isn't there good? So I can ask you a couple of questions. I've heard recently that there's evidence that that a small change in how a patient's feeling before their anaesthetic makes a real measurable difference in their recovery post-op. Is that right?
Yeah, I would say there's a few things about that. There's certainly anxious people generally need more painkillers, need more anaesthetic to go to sleep. Incredibly, well, it's not that incredible, but you're more aroused, aren't you? So you've got to come down further.
It's not just psychology; it's physiology as well.
Well, it's psychology going to your body. I mean, through physiology. That's right. And of course, there's loads of stuff which is similar to general practice. That if we're kind to patients, and you see this, and I see this in everyday life, they just get you and you get them, and it's all just really quite nice. As you say, how can I stop being burnt out? And this is another area which we won't veer into, but it's about how to be an okay doctor for yourself and keep being okay in yourself, isn't it? So it sounds like to recognize that in other people, the shame, that's one of the ways you can understand difficult behavior, perhaps, isn't it?
Yes. Well, I would put that down as empathy. So the simple response to shame. So Brené Brown, who I mentioned at the beginning, would be empathy. And there's a lovely essay by Leslie Jameson, who wrote a book called The Empathy Exams. And she was writing from the perspective of a simulated patient in medical student OSCEs, where they were being graded on empathy. And she wrote what it was like from the patient perspective. And it's an absolutely amazing essay, which you can read online if you look up Empathy Exams and Believer magazine, Leslie Jameson. But she has many quotable parts to that. But one of them is empathy is asking the questions whose answers need to be listened to. And that captures so much of communications training in in one lovely sort of definitive sentence. So what are the answers that need to be listened to, and what questions should you ask? So asking about to find out about kind of shame, or even to find out about somebody's formative experiences when they're growing up. Knowing what questions to ask, so recognizing the kind of some signs and behaviors that people have, and saying, for example, I see a lot of people who suffer with these kind of problems, who use drugs to cope with feelings that they've been having from long ago. Thoughts and memories that keep coming back, and they're just trying to push them away by doing things, burying themselves into work, drinking lots, smoking, having loads of sex, that kind of stuff. Does that apply to you? Asking other questions, maybe about kind of dissociative symptoms that go with shame. Do you ever have blank spots or periods where you just don't feel yourself, or parts of the day that you just can't account for because you can't remember what happened? Or do you ever have sort of seizures, almost like a fit, where you're not quite sure what happened? And patients kind of look at you and think, how do you know? You know, how can you tell? And you think, well, with shame, you know, comes other baggage that people have. So you're asking the questions whose answers need to be listened to. And that she has a little warning, which is important as well, which is empathy is always poised between gift and invasion. See, by that she means you're asking a question that enables the patient to say something incredibly important they haven't been able to tell anyone before. In that way, it's a gift. But it could be just too far and be intrusive. Like, so what happened when you were growing up? Well, actually, I don't feel safe and I don't quite trust you, so maybe I'm not going to go there.
And too much too soon, perhaps.
Yeah.
Maybe.
Yeah.
Perhaps, I don't know.
So empathy. Yeah, empathy is a great kind of way to show that you recognise and know what shame is. And of course, if we've got our own shame and we're aware of it, so self-awareness, then it helps us to say, actually, I think I know what you mean.
Now, we talked previously about superheroes, which is sort of coming to the end. Why do you think the superhero story, or certainly the contemporary narrative of the superhero in the last 10 years has had a lot of shame? Why do the stories have shame in their background? And you've got the Incredible Hulk, I can see behind you there, but Superman 2, Doctor Who, I'm slightly obsessed with Doctor Who, and certainly Peter Capaldi. Well, they've all got shame, actually, all the Doctor Who's.
Trauma as well.
Okay.
Often, well, actually, childhood heroes. Like, how many childhood fantasy figures, parents died in terrible circumstances, or they were orphaned? Yeah. And it goes back a long way. To, you know, Harry Potter, you name it. You know, they've all. You have to get, well, in one way, you have to get rid of the parents because they're a rather boring bit to have in a kid's story. So you want some convenient way to say, here's a child, but they don't have any parents because parents are just dull. But in the superhero thing, just as I said, you know, doctors, like the anaesthetist, you know, you might try to bury yourself in work or be completely excellent or absolutely amazing at something to repair those feelings of actually being fundamentally flawed. So I can somehow compensate for my screwed upness by being completely brilliant at something.
Saving the world.
But it doesn't work. Like, the shame is still there. You're brilliant at something, but the shame is still there. Like, I'm a cyclist. There was a very famous cyclist in a documentary called The Flying Scotsman about Graham O'Brien, who was a kind of case in point, who was the fastest cyclist in the world, but ended up taking his own life. So that being the fastest cyclist in the world was amazing, but didn't compensate for the shame. And it's quite common in so elite sports people. Shame and trauma is overrepresented. The Incredible Hulk I use as an example. His is a story of dissociation. So when Bruce Banner becomes the Hulk, he's triggered. So in a dissociative episode, there's usually a trigger which makes you angry, and then he becomes the Hulk. You know, he can't think, so it's all his limbic system, primitive brain going over in overdrive. His prefrontal cortex, his thinking rational brain, is nowhere to be seen. You can't reason with the Hulk. It's all brainstem and midbrain and just emotional energy. And that's why if somebody's having a panic attack, you can't tell them to calm down. It just doesn't work. You need to give them a hug. If your kids are going completely bananas, there's no point shouting at them and telling them to settle down. You need to distract them or sit with them or do something physical. And of course, the Hulk, to calm down, Black Widow sings him a lullaby.
Oh, is that right? Okay.
But people know the Hulk and they think that, but they don't. And if you're interested in this thing, you think, well, this is classic dissociation. You know, he's triggered, he becomes all emotional and anger, and you can't get through to him, and somebody has to come along and just soothe him like a big baby. but that happens to people who have experienced trauma. So you think, well, what's his trauma? And his dad was an alcoholic who used to beat his mum and him when he was a baby, and ended up killing his mum in a fit of drunken rage in front of him, which is actually in the Marvel comics from the 80s. But people don't often kind of see that bit of the story because it's so incredibly dark. But most superheroes have this really dark past, and often the shift from normal human to superhero has a kind of trigger. And I say the Hulk in particular is a great example of someone who's having dissociative episodes due to their past trauma.
I'm actually just thinking of Genesis already. I don't mean the band, but the Old Testament thing. Of course, that's shame. Is that shame? Did Adam, did he do something that was shameful? Discuss. But
yes,
but I'm just wondering, or also the Norse legends and perhaps the Roman and Greek gods. I'm going to have to go and just check out a bit of Roman and Greek mythology now.
Of course. So shame is used in archetypes.
Yes. Okay.
Part of mythology and particularly kind of Greek mythology, and superheroes are the contemporary sort of version of that. So it's certainly there, and so I suppose in summary, it's universal. Everybody has a bit of it, but some people have a lot more than others. If you've got loads of it, you could call it toxic shame. It manifests as very seriously adverse health outcomes, including addiction and suicide and eating disorders, some of the worst and most sort of life-shortening things you experience in medicine. Being aware of your own shame helps you connect with other people. So Guy Thomas Hubel, who says that kind of shame is what disconnects us. So one response to shame is to hide away and not connect with other people, but it's also what we all have in common. So empathy is how you connect one person's shame with another. And in contemporary examples, so shame doesn't work as a educational aid in medical education.
Yeah, that's right. Okay.
Yeah, so shaming medical students and junior doctors is counterproductive, but also shaming people for behaving badly in a time of COVID, or shaming people for eating too much if they're overweight, or shaming people for not doing enough exercise is almost always counterproductive. It just makes them disengage from anybody who could possibly help them and engage more in the behavior that they're being shamed about. So don't use it as an educational tool, and respond kindly, believe them, validation. And as the two women I spoke to today said, people can recover. Yeah, that's so important to remember.
Yeah, that's very important. Jonathan, I think we'll probably end there, but I just want to say thank you so much for talking. It's been really enjoyable. And to the students, they'll find it, I know, really, really interesting and valuable.